Okay, let's go ahead and get started. Stephen, are you ready?
Yep.
Okay. We have Dr. Stephen Velez giving grand rounds today. Dr. Velez is an Air Force veteran, having served 4 years as a survival instructor prior to using his GI Bill to attend Texas Tech University, where he earned a degree in nutrition, graduating with honors. He then attended the Long School of Medicine at the University of Texas Health Science Center in San Antonio, graduating in 2020. Moving on to psychiatry residency at the University of Washington, Idaho Psychiatry Residency track, where he will be graduating this June. He has always had an interest in systems issues and how they relate to patients and practitioners' mental health, and is happy to discuss these topics with you today. And without further ado, Stephen, take it away.
Thank you, Dr. Browning. I will be discussing structural competency and seeing the whole patient. Something that I recently learned about an elective I had with Dr. Nard Sue, which had me consider patients in the systems we work in a different way, which was I thought was helpful. Some of the objectives that we're going to be covering today is understanding the concepts behind structural competency, well, the difference between cultural competency, which many of us probably have heard about, and structural competency, how these factors affect the patient's health, and then developing structural ability. Much of this information that I got is from this article that was put out in 2015 in the Social Science of Medicine, titled Structural Competency, Theorizing a New Medical Engagement with Stigma and Inequality. This was put out by Jonathan Metzl, who's a psychiatrist, as well as Helena Hansen, also a psychiatrist and anthropologist, who did a lot of work in finding why these systems seem to fail and why a lot of our patients struggle. To make this kind of a little more down to earth and something that we can kind of look at, I'd like to follow a patient that I worked with. Actually worked with this patient prior to learning structural competency. So we'll see kind of how that affected him, what changes I may have tried to implement to better his care. So Mr. C is a 57-year-old man, initially referred to me for psychotherapy in one of my clinics. His PCP wanted him to get treatment specifically for anxiety. And then when on our intake, Mr. C described and wanted to work on most was overcoming difficulties that he experienced throughout life and that he thought were kind of affecting his ability to participate in the social environment, do what he wanted to do. At the time that I saw him, he was unemployed. He was unstably housed. He was living out of his vehicle. Had never been married, had one daughter that he really had no contact with and really didn't even know about until maybe a year prior to seeing me. He'd been estranged from the majority of his family, a few social ties, and he described feeling anxious and worried about many things: daily finances, housing, things that happened to him in the past, and what was going to happen in the future. He often felt overwhelmed with these problems and reported that he would self-medicate with the daily cannabis use and daily alcohol use, which he thought would precipitate a lot of the problems and wouldn't necessarily be helpful, but he said it was the only way that he found he was able to fall asleep. He used those substances. So he was diagnosed and met criteria for general anxiety disorder, major depressive disorder, post-traumatic stress disorder, alcohol use disorder, inheritance use disorder. So a lot of these disorders, and then we decided to continue with therapy. In addition to a lot of his mental health concerns, he had quite a few medical concerns as well. He had the diagnosis of type 2 diabetes, not well controlled. He was on several different medications. With having had diabetes for so long, he also had diabetic neuropathy, hypertension, hyperlipidemia. He really struggled with maintaining his health. And I think a lot of that is due to the social factors of where he's living. He didn't have a kitchen to cook in, so a lot of things that were affecting both his mental health as well as his physical health. So we'll keep it in mind as we kind of work through what structural competency is. So what is structural competency? As defined by Metzel and Hansen in their paper, it's the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases, depression, hypertension, obesity, smoking, medication, noncompliance, trauma, psychosis, also represent the downstream implications of a number of upstream decisions about such matters as healthcare, food delivery systems, zoning laws, urban and rural infrastructures, medicalization, or even about the very definition of illness and health. So a long definition can clear up what a lot of that goes into. Within their paper, they talk about 5 core competencies of structural competency, and those are recognizing the structures that shape clinical interactions, developing an extra clinical language of structure, rearticulating culture, formulations in structural terms, observing and imagining structural interventions, and eventually developing structural humilities. There's really tenets that go into structural competency and that kind of build on each other and give us a whole picture. So we'll work through these 5 different competencies. For the first one, so the first one, structures that shape clinical interactions. So what is considered part of the structural landscape? And the formulation given by Metzel and Hansen, structure really implies a lot of different things that we may not even consider within our clinical interactions. They pose that it implies buildings where we house our clinics, where our clinics are located within the cities that we are practicing, where patients are living within those cities or outside of those cities. They also go into energy networks. So how affordable is electricity? How affordable is gas? And how reliable are those networks? During the winter, are they able to afford keep the heat on? Are they able to afford electricity? Those type of things. It also goes into water systems. Is the water we drink free of contaminations? Waste distribution systems, the sewage properly disposed of, transportation systems, are they regularly kept up? Are the roads regularly kept up with? Is there reliable and convenient public transportation? Electronic communication systems, do our patients have access to the internet to look up things about their health? Or are they able to afford a phone so they can call into the clinic when they need help? And it goes even further to include our education systems as well as medical systems. I think there are many examples of these systems failing in causing adverse health effects. I'm sure all of us have heard of Flint, Michigan, and lead contamination in their drinking water. As they observed this, they estimated that up to 12,000 children have been exposed to contaminated drinking water. That can lead to significant health and even mental health difficulties with causing intellectual function decline as well as other health conditions. Waste systems can also be critical infrastructure. I was able to read a book called Waste by Catherine Coleman Flowers, where she describes working to resolve the wastewater crisis in rural Alabama, in which many residents who paid into the waste management system, they ended up breaking down, and they would have raw sewage draining into their yards, which caused significant, spread of disease and health issues, and as I can imagine, also some mental health, anxiety, and likely depression. And when these issues were brought up with their local government, their decision to resolve this ended up being to arrest people that weren't able to fix these systems and had the free flowing sewage. So a lot of systems level failures, and then poor ways of addressing those failures. As healthcare mental health providers, we often see the downstream effects of these systems failing when our patients come to our clinics. So the next core tenet is developing an extra clinical language of structure. So looking beyond our hospitals, beyond our clinics, it goes in how we need to understand the way these structures influence illness and health in the community setting. This is not really a new concept, but something that we've likely all heard of in the term of social determinants of health and how those determinants affect us. So what are the social determinants of health? This is something I got from the U.S. Department of Health and Human Services. There are conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning, quality, or quality of life outcomes and risks. So they go into different domains, including economic stability, educational access and quality, healthcare access and quality, neighborhood and built environment, social and community context. The reason Dr. Metzel and Hansen argue that the term structural instead of using the term structural instead of social is that social as a term is very diffuse, whereas structural implies that there are specific institutional organizations and policies that we can look to for change and see those kind of downstream effects. I'd like to just kind of look at one of those social determinants of health, which was how cost and income can affect access to healthcare. So this is data collected from the Health System Tracker. It was collected from the 2022 National Health Interview Survey. They showed that 28% of respondents to the survey delayed or did not get healthcare due to cost, while 45% worried about their ability to pay medical bills if they were to get sick or have an accident, and would often delay getting care or not even go in to get care if those occurred. Looking further into that, the data also showed that it affected Hispanic adults more than others, as well as adults in worse healthcare. And uninsured adults are more likely to report foregoing care due to these costs. These numbers include adults who reported delay for not getting medical, mental health, and dental care due to costs, as well as those who reported delayed, not getting, skipping, or taking fewer doses of the prescription drug. drugs due to cost. So not going in, not getting their care, as well as not being able to afford their medications, and trying to skip those. This is an image that I got from an article titled "The Social Determinants of Mental Health." It was by Dr. Michael Compton and Dr. Rich Shim, published in Focus in 2015. It shows kind of a diagram here, how we can look at kind of the base here, where public policies and social norms can go into kind of distribution opportunities, whether that's financial or just resources such as food or housing, those type of things. And if you're in an area where those are a reduced resource, you may see un or underemployment and reduced job security, which can also show up as adverse early life experiences, food insecurity, discrimination and social exclusion, poorly built environments, poor education, housing insecurity, poverty, income. And we see moving up to the next level, it can cause reduced options for people, which can lead to poor choices and high risk behavior, as well as increased stress. If we look off to the right side of we can see these two arrows going up into genetic risks, which we've seen more and more that high stress levels can, especially the exposure of high stress levels at early age, can lead to further genetic risks, higher levels of stress hormones, which can contribute to long-term health risks. If we keep on looking up, going up the scale here, we'll see social, environmental, and behavioral risks, and lead to poor mental health, disease, and morbidity. And some of these, if you look off to the left, see how public policy can affect some of these systems with, ability to afford healthcare systems, and then access to care, especially if you're living in an area where there's reduced mental health practitioners, or just reduced care in general. Research has shown how resource poor environments can cause physiological and cellular adaptive responses, such as DNA methylation in early development that can lead to chronic disease susceptibility, such as diabetes, coronary heart disease, depression, and substance use. So exposure to these adverse events, or these resource poor environments, can lead to poor health and well-being. All right, so continue to look at Mr. C, in really trying to take an extra clinical look at what structural systems may have impacted his current presentation. Mr. C was born in New Jersey. He was the middle child with one older sister and one younger brother. His parents, who were originally from Puerto Rico, eventually moved back when he was at a young age, just about 2 years old, and in order to live close to his family. He reported that his time in Puerto Rico was some of the best he had in his life. There was a lot of extended family that he socialized with, cousins and uncles and aunts, and in the community that he felt connected to. But his parents eventually left Puerto Rico when he was about 12 due to financial constraints in wanting to get. They eventually moved back to New Jersey. His family struggled with finances and lived in a low socioeconomic area, with his father working several jobs to support their family. Excuse me. At one point, he reports that he got to live with what he called a religious family for about a year due to financial issues with his family, and then also disruptive behavior he had been exhibiting. He also reports exposure to verbal and emotional and physical abuse, primarily from his mother, who he thought suffered from mental health disorder, but he was unsure that she was ever diagnosed with anything. He also described that he and his siblings were not allowed to go play outside in the evenings, and that he described staying inside most days. So they'd get off from school, come home, and then his mother wouldn't allow them to go outside and play with their kids because she thought it would be unsafe. He also felt that his father was disconnected, never really talked to him, and had worked all the time, so never really felt like he was a good father figure in his family. Eventually, he left home when he was about 15 years old to live on his own. He would often stay at friends' homes or in a rental property with his a family that he knew. He had dropped out of school in the 9th grade, though eventually received his GED and then joined the Navy, where he worked as a barber for his term there. He reports never really having any stable employment. He often worked on bench jobs as a day laborer. He never really had any long-term relationships that he described, and was estranged from his family. I hadn't talked to them in many years. He had recently connected with a daughter who was 38, and he met for the first time when he was 7. Though shortly after they connected again, they stopped talking due to some poor interactions between her and so they lost that connection as well. He had an extensive history of substance use. He started using alcohol with alcohol and cannabis when he was about 15 years old, and had several periods of time where he maintained sobriety through the help of campaign and friends that he had during those times, though sobriety never lasted for very long. He had occasional stimulant and opioid use, but no regular use, or as described before, he was living out of his car, was unemployed, but did find occasional jobs that paid a few $100s here and there. He was on Medicaid that funded his medical bills and ability to get medications. Though did find it difficult to pay for medications at times, and often would delay getting medications or reduce the amount of medications he was taking in a ration without what he wasn't able to afford them. We can see that from an early age, Mr. C grew up in a resource poor environment. We can also infer that the neighborhood he grew up in was likely not very safe, as his mother often wanted to stay indoors. His access to quality education was likely poor, and remained poor as he dropped out of school at an early age. If we look at Mr. C through the lens of structure, we can begin to articulate how his current presentation can be understood as a product of social structures interacting with biologic. So that leads us into the third concept here, re-articulating culture, presentation in structural terms. Cultural competency implies that the trained ability to identify cross-cultural expressions of illness and health, and help to counteract marginalization of patients based on race, ethnicity, social class, religion, sexual orientation, or other markers of difference. Research has found when clinicians use social cultural information, they are more empathetic towards patients. They individuate patients and have a greater understanding of the patient's clinical presentation, which better informs their diagnosis and enables the clinician to differentiate psychopathology from the contextual circumstances that influence behavior. This so according to Metzl and Hansen, culture deployed in the clinical setting emphasizes familiarity with the values of different class groups or ethnic communities, while potentially facing recognition of the deeper ways in which complex cultural structures produce inequalities. Structural language allows for emphasis in how cultural barriers come about with structural forces, cause disruption in interpersonal communication, influenced by institutional practices. Structural exploration might bring about questions such as what social infrastructure or economic factors might cause delays or interruptions in the patient's mental health care, what community factors might impact care for the better or might impact care negatively. Also looking at the structural aspects might lead to greater collaboration between clinicians, social workers, and other community groups that would allow for better access and better treatment of their health and mental health. Number 4 is observing and imagining structural interventions. Structures that shape health and illness are neither timeless nor immutable, but instead reflect specific financial, legislative, or indeed cultural decisions made at particular moments in time. At this point, we recognize that structures impact patients' and clinicians' experiences. Now, how can we intervene, or what can we do to promote better and improved health? So, how to promote structural interventions? We can integrate community-based care, going to the patients, making access to care more convenient and patients more able to get to the clinic or clinicians able to get to the patients. Include social conditions and housing and mental health interventions. Collaborating with community organizations, law enforcement, schools, addressing trauma and violence in lower socioeconomic areas, advocating for health, promoting public policies, and focusing on structural rather than an individual level. I had the opportunity in medical school at the University of Texas in San Antonio to learn about and volunteer at the Haven for Hope. It was a local nonprofit organization that focused on providing social support and healthcare to low socioeconomic and undeserved people in the city. They had a diverse array of programs to meet people's needs. They would provide financial support for families that were struggling to make rent in order to prevent them from losing their housing, which was more financially feasible than helping patients after they've already lost their housing. They also provide low-income housing at their site to families who have lost their homes temporarily, and the idea that they would support them through this time, help them get resources, help them find jobs, and allow them to then transition to housing outside of their specific facility. They also provided a courtyard that would be a safe place for people that were living with homelessness to sleep at night, allowed them to get off the streets in what might be an unsafe area, and provided that safe space for them. Also provided places where they can store their belongings if they weren't able to take them with them for several days. Also provided social work and resources to help them gain funding, such as Social Security, get them connected on Medicaid or Medicare, and just provided them with an address that they could send mail to when they are trying to get a job or get these resources. On their campus, they provided social support, such as help with government benefits, providing directs for people. This was a collaboration between the city, so partially funded by the city, as well as local businesses that both saw the benefit of helping the community and helping those. There are other tools that you can use even within your clinic that might help open your eyes to what your patient might be struggling with. There's the structural vulnerability assessment tool, which is a 43-item questionnaire that can be used to assess the needs. It assesses 6 domains to include economic stability, education, social and community context, health and clinical care, neighborhood and physical environmental, and food insecurities. It's a tool that people can use during their initial intake. That gives them a better idea of the areas where clients or patients are struggling in areas that we may be able to intervene at. But going forward, you know, what's going on with Mr. C? So after I had worked with Mr. C for several months, in which time we had planned for weekly psychotherapy sessions, to work on kind of anxiety, as well as him trying to resolve some of his past experiences. Though he would only come to about 60% of his appointments, likely due to a wide array of different difficulties. He would find jobs that may prevent him from coming to his appointments, just due to either him making money that day or not making money that day. Sometimes he couldn't afford gas to drive over from where he was staying to the appointment. So all array of different social factors that affected his ability to even come to his therapy appointments. Eventually, he abruptly stopped coming, and I was unable to reach him. But he had been working with the case manager to attain social security disability and other services that he was trying to get. And through talking to them and learning, I was able to learn from what had been going on with Mr. C and what caused him to kind of abruptly end his psychotherapy sessions. He had been working with me on getting his finances on track, and getting his vehicle reinsured, and getting it planned on getting it registered, which it hadn't been, he said, for years. He was also working on trying to work on sobriety. He was drinking daily in the evenings, and realized that was affecting his physical health, given that he had diabetes and cardiovascular risk factors that were poorly controlled, and he knew that his alcohol consumption was contributing to those health factors, as well as mental health. So he'd been working on getting sober, which had been difficult. He had been behind on payments with his vehicle, and it was eventually repossessed. At that point, he had no transportation and had nowhere to store his belongings. And for this reason, he was unable to make it to therapy. And it was kind of on the lower end of what he was trying to benefit from. Through, or he eventually started a job at a fast food restaurant, was saving up to receive another, or to buy another vehicle. With his new job, his employer had made a mistake on how much he was making a month, and with him making as much as his employer had said, he ended up losing Medicaid services, which led to further difficulties in his ability to access his medical care. He was unable to afford his medications at all, unable to afford his follow-up appointments, which led to further difficulty. We can see that Mr. C had been working to improve his mental health and his physical health. He wanted to become more financially stable, and there were definitely system level issues that were preventing him from attaining those goals, and improving his mental and physical health. Eventually, his Medicaid eligibility was straightened out after a few months, and then he started receiving disability benefits. This allowed him to purchase a new vehicle that he began to live out of, and then allowed him to take time away from work to address his substance use. He went to the Alaba House to detox, and then eventually transitioned to a residential substance use program to try to maintain sobriety. So kind of our last concept here is developing structural humility, which is recognizing the limitations of structural competency. It's a newer concept that is continuing to evolve. And so we keep awareness of the complexity of structures involved is only productive as long as practitioners recognize that the skills discussed are the beginning points of the conversation, not the end points. And then finally, structural competency. This was from the website, structuralcompetency.org. We describe structural competency and calls for a new approach to the relationship among race, class, and symptom expression. It bridges research on social determinants of health to clinical interventions. It prepares clinicians, clinical trainees to act on systemic causes of health inequalities. Structural competency aims to develop a language and set of interventions to reduce health inequalities at the level of neighborhoods, institutions, and policies. That the end. Do we have any questions? Went by a little faster than I expected. I talked a little faster than I did in practice. So, yeah, any questions or comments, or if other people have made resources they found in the community?
I have a question, but for some reason my video is not showing up. So I'll just ask it. When you're talking to patients about the way structures in their life impact them, how has that gone? Like what kind of language do you find is accessible to them, or what kind of approach?
Yeah.
In terms of relating the structural issues to what they're seeing you for?
I'm not sure I talked to them like directly about the structural issues. I think it's more like a concept that I found that after learning about, I kind of applied to like their current presentation. And something that I elicit from them, like what, yes, you're coming to me because you're depressed or anxious, but what are the social constructs outside of this that might be contributing to that? So I think at first finding out kind of what is affecting your life as a whole. And then really when talking to them, you know, a lot of what I preface is, hey, we're going to prescribe these medications, we're going to, but they're not going to necessarily change the environment that you're currently living in that might be affecting you that way. And so I think it broadens my idea of what kind of resources they may need in addition to coming to me for medications or therapy or whatever it is. Like in Mr. C's case, I think, you know, if I had noted these concepts earlier, I may have recognized that the clinic that I was in maybe wasn't enough support for him. Maybe he needed more kind of wraparound services where he had peer support, a substance use counselor, a case manager in the same place, somewhere where he could go, because that, you know, at this clinic, I'm only there once a week. And so somewhere where he could get a more broader range of days and hours that he could go, or acute access, that kind of stuff. But I think recognizing the limitations of what I can provide and ensuring like what I'm providing the best care for this patient, or should I refer them to, you know, somewhere else. So I don't necessarily, I guess, tell them directly, this is affecting you, it's because of the policies that are in place. I think it's more kind of my conceptualization, and then through that, making sure I'm giving appropriate care.
I have a follow-up for that. That's very interesting. Did he connect his situation, his social stressors to his mental health symptoms? When he was giving his narrative, did he make that connection, or were you making that connection for him, with him? Tell me how that went.
I think it came through a few times that he would be able to kind of connect that, you know, he, especially when it kind of revolved around substance use, you know, he would say, you know, I feel like I'm in this kind of dark hole, I feel depressed, and he was, you know, very depressed, especially when at night, when he was kind of in his vehicle trying to fall asleep in this like not very comfortable area, and you know, watching a video or YouTube or whatever on his phone, he started to kind of experience kind of deeper depression, and he's like, the only way out of it, or the only way I could fall asleep is like pass out. So I drink, you know, enough beer and smoke enough cannabis, so I don't think about these things anymore. So that was kind of the level that he kind of reflected on, kind of social constraints and how they were affecting him. Yeah, I mean, on my level, I'm like, you got a lot going on, a lot of difficulties, and I don't think, you know, the SSRI is, you know, gonna cut it. So for me, it was connecting, trying to, looking back now, I would try to connect a lot of the other, you know, issues, and maybe provide a lot more kind of validation to him about what he's going through, his experience, and how, and normalize some of those feelings. I think if, you know, if any of us were in that situation, we would be feeling very similarly. So I think, yeah.
That's great. That's awesome. Thank you I really enjoyed the presentation. So thank you for that.
I just wanted to comment that I thought that was great. You know, you and I have talked a lot about structural competency and how it equates to patient care and all the different layers and levels of interaction that we have with the system, being part of the system, and then how patients have to interact with that same system, but from a different perspective. And kind of like how those two pieces come down to those two people in the room, and how it's really helpful to recognize all of these barriers to their treatment, maybe pre-existing barriers, existing barriers that are preventing them from engaging in treatment, and then future barriers when people fall on off insurance panels or whatever happens. So I really appreciate that you talked a lot about the structural pieces and components of kind of how these systems develop and shape our relationships with our patient population. One question I had for you was about kind of how you interpret the cultural aspect of this. You know, like how do you kind of use that cultural competency lens to kind of, you know, apply it to patients when we have the structural lens in place?
Yeah, for sure. I think, you know, relating back to that, Mr. C, you know, he was from this Hispanic descent. He's originally from Puerto Rico. So I think his thought process on like what he was struggling with, and even him coming into therapy was a bit difficult. You know, there's this like machismo. So if you're, you know, Hispanic, my grandparents were from Mexico, and so, you know, I grew up in some of the same kind of cultural, and so there's this thought that, you know, you should be able to kind of take care of these things on your own. You should be able to stand up on your own, and reaching out for help might not be the most easiest thing. So I think that definitely played a role, and it may have played a role in his ability to come into therapy on a regular basis, as he did often miss. And so maybe, you know, some days he was feeling vulnerable and able to come in, and other days he was like, he may not have felt that way. And I think that definitely plays a role. I know we talked a lot about the culture and the way, you know, we as medicine and mental health tend to pathologize a lot of things that you know, in certain cultures may not necessarily be out of the norm. So yeah, I don't know. So thinking about all of this, it's a lot to think about, if you're meeting somebody for the first time. But with him, I think I don't know if you had more to add. Dr. Sue was my mentor for this, so, and she's the one who first presented structural competency to me. So
I don't have anything else to add. That was great.
Hey, this is Abhilash. Great presentation again. It's new learning, so we're all at the ABC level of learning, forget words and language, you know. To me, you know, if there was a social worker who's like the expert in community resources and other things, then I could talk to them and say, if you were in my place, what was the first thing you would do? What was the second thing you would do? But I don't think we have that kind of access, correct? Okay, all right. Anyway.
yeah, I think that's, you know, and that's something that they bring up in the paper, is that, you know, we can't put this all on one person's shoulder, right, to do all of this. You know, this needs to be kind of a collaborative effort between, you know, social workers, you know, counselors, physicians, primary care, mental health, like the whole gamut has to work together to help kind of resolve some of these system level issues, which are higher and higher. So this isn't like yeah, this is all on you. This is one of those, you know, we need to collaborate. And as a system, like a medical system, like collaboration, integrated more. At least in the future.
I did want to add one thing. I was thinking a lot about Maslow's hierarchy of needs during this presentation. I think in another way, that's sort of how I've thought about these issues. But of course, we know the pyramid's very simple. I think this kind of breaks it down into some fine threads.
Yeah, no, I totally agree. And that's, you know, if you don't have a car, you don't have a job, and you're kind of losing everything at once, you know, you can want to come in once, or be able to come in like once a week. Obviously, your issues are great. There's a lot more that you can do with that hour. than talk about the problem, even though it would likely help to have a supportive person. I'm sure in the moment it's hard to realize that.
Stephen, I have a comment. I really like how, I mean, I've heard about social determinants for a while, but like you said, if you conceptualize it as structural and that these are certain decisions that are in place, that they're changeable too. It helps us see certain changes that could be done. And one thing I've found, and maybe you could talk about, is I think it's underappreciated the shame people have when they don't have money or resources. And if we're not careful, then they're they're embarrassed they don't have a car that works. And so that there's a way that we can help people talk about it and empathize with it rather than, so there's a lot of shame with the poverty, which a lot of times shouldn't be there.
Yeah, definitely. And then in his case, he'd actually have like warrants out for his arrest at that time, which he never told me, but I learned from the case manager, and which prevented him from going, to like shelters and stuff like that. And I'm sure shame definitely played a role in that. That he didn't want to, tell me about these kind of other issues that may have been going on. And I think a lot of it goes into, validating their experience. That can be one of the best things that you can do in the moment. It's kind of validating those feelings and what they're going through. Which, doesn't sound like a lot, but tends to help people.
Yeah, Stephen, I just wanted to thank you so much for your time and everything. This is such an important discussion. I work at the Healthcare for Homeless Veterans over in Boise, VA. And, it's a lot because I've been there. I've been homeless. I've had my struggles with alcoholism, and I've been in recovery for almost 4 years now. But, I get to show people that there's hope and that everything, but I'm still fighting a system that when I go some places people want to label me as a statistic, and we don't talk about what I'm doing in recovery and what kind of life I live now. Instead they just want to push me off to somebody else. So I just really appreciate the fact that you have this discussion, that you can see the whole picture and not just that label that we might put with somebody. And and it's important for me, even as a patient, to say, I don't know what kind of experience you may have with people like me. And maybe you have a daughter who's going through the same thing, and you just want to push it aside. So I think it's just coming to that understanding. I really appreciate you talking about this today.
Thank you. Thank you for sharing.
Any other questions for Dr. Velez? Thank you. Thanks for a great presentation. I guess we'll wrap up at this point.